Great stuff. Okay, thanks very much, Kish. Thanks very much for the invite to come and speak at this excellent forum. It's great to see so many people here for a shared interest. I've been asked to speak to you today about complex urological abnormalities. I'm Dr. Trevor, Gaunt, consultant paediatric radiologist at University College London Hospitals in London. I'm also an honorary associate professor in the maternal fetal medicine department. And I'm going to talk to you a little bit differently about one of the questions that I think is the most difficult thing to answer when we're doing these kind of scans for the fetal medicine team. And this is something that was actually asked to us not so long ago in our meeting, as how disabled would our baby be if we continue with our pregnancy? And that's what I think the essence of doing this is all for, right? There's a patient at the center, there's a family making very difficult decisions, and something we've got to try and help out with. So I'm going to keep this as a theme and come back to it in a little while. I'm going to give you a little bit of an overview of the anatomy, sequences and signal that we use in body imaging. A very small, brief developmental explainer about the urogenital system. And then we're going to talk about a few of the things that we've got listed here: clycal malformations, persistent UG sinuses, bladder exstrophy, OAIS subcomplex, and then some of their implications. I decided not to go and talk about things like hydronephrosis and renal agenesis, just because I think it's something that's so commonly dealt with. And most of the time, fetal medicine units can deal with that on their own on ultrasound. We do occasionally get to asked to do an MRI for if there's a poor lie or if there's oligohydramnios or something like that. But I think this particular problem, complex urogenital abnormalities, is a very difficult, challenging constellation of problems for fetal medicine and the families involved. So we're used to the anatomy. I'm not going to dwell on this too much, but what we have here on the left-hand side is a male anatomy. You see bladder, rectum, that's fine, a bladder, uterus, vagina, and rectum in the female. The sequences that we use in body imaging similar to those that we use in the brain, but have particular uses within the body, which we're going to talk about here. So T2 haste, we use 3 planes. It's high signal urine and amniotic fluid, which we all know, but the low signal voids are often quite good for demonstrating blood vessels, and it shows us excellent contrast resolution. We can see that here. You can see a nice big bladder just here. We also use a Truffi sequence. Sometimes it gives slightly better spatial resolution, we find. Gives high signal fluid-filled structures again. Also high signal blood vessels with good contrast with the spin echo sequences, and also gives excellent contrast resolution once again. And here we go. You can see a bladder here, and all that kind of CSF with good contrast resolution once more. But this is the real one we're going to talk about, and I think is most useful in answering the question of complex urogenital malformations, which we've touched on a little bit in previous talks, but this is a T1 sequence, and in this context, it's meconium that's really, really important. High signal on T1, it should extend all the way down to the perineal surface in the normal fetus, and if it doesn't, we have to ask why. We can see that here. There's a coronal sequence, high signal meconium going all the way down to the perineum, and then similarly here on the sagittal. So these are 2 really important sequences to get right when we're doing complex urogenital malformation type work. We also do coronal DWI type sequences with p-values of 0 and 700. And the kidneys restrict diffusion really nicely. You can see on the left-hand side, this is the DWI and this is the ADC. That's really good for showing whether there's any renal tissue present or whether it's absent and associated with some of the complex malformations that we see. Okay, a very brief developmental explainer. How do we get to this point? All right, well, in the first 3 to 4 weeks, there's the cloaca, and that's the kind of main thing that's going to be the cause of the problems if it just doesn't develop properly with what we're talking about. The cloaca is an endothelial-lined terminal cavity, and it's a common chamber that receives what eventually becomes the bladder and the genitourinary system, and the hindgut posteriorly, which becomes the future rectum and the anal canal. That's what this looks like, this kind of schematic diagram here. So this is the atlantois, which eventually becomes the bladder. This is the hindgut, which eventually then becomes the rectum and the anus. And there's this small amount of mesenchyme here, which is the urogenital septum, which is eventually going to come down to the cloacal membrane and divide the 2. And this is the cloaca. This is the common chamber. And if this persists, then there's problems. By weeks 4 to 5, that mesodermal wedge is starting grossly caudally down towards the cloacal membrane and eventually divides the cloaca. It forms the urogenital sinus anteriorly and the hindgut posteriorly. And I think this is really important to know when we're talking about these kind of problems. If you have an idea of how the development works, you can have an idea of how the pathology works. And if you know how the pathology works, you know which signal and which sequences to use when you're interpreting the images. So here we are. We can see the urogenital sinus here, and the urorectal septum is starting to grow caudally down towards the cloacal membrane and starting to part the 2 in between. At this point here, this is the urogenital sinus. This is eventually the common tract between the urinary system and the uterus and the vagina in the female fetus, and if it persists, then this also causes problems, which we're going to go into a bit later on as well. By week 6 to 7, the cloaca starts to divide, and it divides in completely. You've got the urogenital sinus anteriorly, which forms the bladder and urethra, and posteriorly you've got an anorectal canal, which again forms the rectum and the upper anus. And that's what this eventually looks like here. You've still got the allantois, which eventually will become the urachus, which will obliterate in normal fetal life, normal neonatal life. And then the urinary bladder here, and then the rectum just here. So this is a completely divided cloaca. And at this point, you end up in week 6 to 7 with a urogenital opening and an anal opening, which we can see just here. Now, it's useful to bear in mind that at this point, these are membranes. Okay, they're not fully formed orifices. During the development, they're membranes, and if they rupture early, then they cause problems and prolapses and the extrophies that we're going to catch up with a little bit later. Okay, so by gestational weeks 8 to 12, everything should be completely differentiated and organogenesis should have finished. So in the upper region of the urogenital sinus, we've got the bladder, but not the trigone. In the pelvic part, there's the female urethra and the lower vagina. And in the male, it becomes the prostatic membranous urethra. And then there's a phallic component, which is the most caudal component, which in the female produces the vagina and in the male produces the penis. So you can imagine at any point, if something goes wrong here, then organogenesis for all of these things becomes problematic and then requires reconstruction if the fetus makes it to neonatal life. So that's how we end up there. Good, so we're going to talk a little bit about cloacal malformation so far, and it's cloacal separation failure. Get incomplete urorectal septum development with a single common channel that drains the bladder, the vagina, and the rectum. You end up with an imperforate anus, and quite frequently you end up with spinal defects, which we'll come to a little bit later, and often you get renal anomalies because they're part of they develop from similar apparatus in very early fetal life. This we've just looked at. And on imaging, what are we going to find? Well, most of the time, the sonographers or the fetal medicine team will tell us that they found a midline pelvic cystic structure, which isn't the bladder, and they can't identify otherwise. There's usually absent distal meconium signal on an MRI, and there may or may not be hydronephrosis, depending to which the extent that the renal system is involved. Quite frequently, you have a distended proximal bowel because there's no rectum that's formed to allow for this meconium to pass distally, so it backs up. And then often, if you have a fistula or you have a common channel, you're going to end up with mixed fluid and meconium signal in the bowel, which shouldn't be the case. There should be no fluid signal in the distal bowel in the fetus. You may or may not have hydrometric colpos, and quite frequently, if it's a big obstruction, then you'll end up with fetal ascites as well. So here's a case of a 29-week fetus. The fetal medicine team told us that there was a multicystic kidney with ascites and that there was megacystis at 20 weeks, which has since resolved. And there was an echogenic distal bowel loop. They were worried that there was a cloacal malformation, but they couldn't tell us whether it really was or not, so they asked for help. This is the ultrasound, but this in fact is the bladder, but this is the midline cystic structure, which they said since resolved. This is the left kidney, which you can see is dysplastic, lots of individual cysts with echogenic stroma with no corticomedullary differentiation. And then on the right, there's a normal looking kidney, which may be a little bit dilated. So we did an MRI, and what did we find? Well, this is in fact a bladder here. And then this is the midline cystic structure that they were talking about, okay? Now, what else do we find? These two little things here, these are the fallopian tubes which are distended, and then probably accounts for fluid leaking out through that, causing the fetal ascites. But this distal bowel loop that they asked us about is this thing just here. Okay, now this doesn't make it all the way down dorsal to the bladder and anterior to the sacrum. Okay, it's abnormal. There's mixed low signal, mixed high signal on T2, which suggests that there's mixing of meconium and fluid. You can see it similarly here. With a dysplastic kidney just on the left. This is a very dilated abnormal loop of bowel which has mixed fluid and meconium signal. You can see that on the T1 here. This is kind of a rim of meconium and a fluid on the inside just there. So yeah, and here's the hydronephrotic right kidney, and here is multicystic dysplastic left kidney. So a constellation of abnormalities, which eventually we kind of be able to say that this is a cloacal malformation. You've got features of all of these things which can't be explained by anything else. And this is the strength of MRI. Right, they had a good idea on ultrasound, but they can't tell always. And what we've been able to do is demonstrate the anatomy and characterize the tissues that we're looking at through the signal and sequences that we use in fetal MR. A persistent urogenital sinus is develops when there's incomplete division of the urogenital sinus in a female fetus. You get distal urogenital sinus remodeling problems. It doesn't completely separate out during those kind of like mid-weeks of organogenesis. You generally get a common channel which drains the urinary and the genital tracts, but it can be very low and it can be stenotic. So you can get the impression that there is a normally formed bladder with a dilated genital system, which we'll see in a second, or there can just be a complete chamber that drains both systems as well. In those cases, when it's most severe, you don't see a separate bladder, you don't see a separate urethra or a vaginal canal when it's at its worst. On imaging, the sonographers and the fetal medicine team will see a single perineal opening. They may or may not have hydronephrosis depending on the degree of stenosis, and they'll have hydrometrial colpos quite frequently as well. The meconium signal, importantly, does extend to the perineum, and this is why it's so important to have a good sagittal, or it's a good coronal T1 sequence, where you can see that extend all the way down to the perineum. You can be confident that at least the urogenitory system and the hindgut are separate. So here's a case, 30-week +4, midline pelvic cyst seen on ultrasound, bladder was seen present. There was a normal anal opening, but the fetus had ascites. So here we go. Here's a normal bladder, so large volume ascites, and then this big cystic structure in here, which we managed to see on MRI. Now, this again is the bladder. This is an axial T2 haste. Here we can see this is a very distended chamber, which is dorsal to the bladder and anterior to the rectum, which is fluid distended, and then up and over the top here, there's this comma-shaped looking thing, and that's the uterus. So this fetus has hydrometrial colpos, but also has a bladder present. But importantly, on the MRI, they have meconium extending all the way down to the perineal surface. So we can see that the two systems are separate, and we can be confident that there's hydrometrial colpos, but a normal rectum, and therefore this is a persistent urogenital sinus, which is likely a low common chamber with a stenotic opening. And once again, MRI is shown. The anatomy is easy to demonstrate, and we can characterize the tissues and the signal things that we're looking at with MRI. To left, this is bladder exstrophy. Now, this is fairly common. It's for abdominal wall closure failure. There's a lower abdominal and bladder wall remain open and everted to the outside world. So you've got the inside of what would be the bladder kind of everted and looking out into the amniotic cavity. The bladder and the mucosa are exposed on the abdominal surface, and the ureter orifices open out into the amniotic cavity. And that's why the Lycor volume is normal in bladder exstrophy. If you have a fetus who has an absent bladder, but the Lycor volume is normal, then you can quite confidently start looking at whether this is a bladder exstrophy, provided, as we'll see in a second, that things like the meconium signal are normal. Quite frequently, the umbilicus is low in this case because of the eversion in the exstrophy. And if it's a male fetus, there are often genital abnormalities as well. So like epispadias, hyperspadias, and various things like that. On imaging, like I said, the bladder can't be visualized. There's normal Lycor volume, but importantly, the meconium signal extends all the way to the perineal surface again. So here's a case, 21+2, normal Lycor volume, bladder not visualized on ultrasound. This is a young fetus, but you can see here, there's no bladder throughout the entire scan, and all the Lycor volume is completely normal. And then we can see on the T1 sequence, this is a coronal sequence. We can see that there's high signal meconium extending all the way down to the perineum. And just for fun, we've got a second one as well. So this is a slightly older fetus, 32+3, normal Lycor volume, bladder wasn't visualized again on ultrasound. Once more, you can see here, there's a low infraumbilical anterior abdominal wall defect with no bladder throughout the whole scan. And this is a slightly older fetus, but the Lycor volume here is normal. We can see on the T1 sequence, importantly, like I said before, that the meconium signal extends all the way down to the perineal surface. So we're confident that the urogenital and the hindgut systems are both separate. And here we can be confident again that there's bladder exstrophy. Now, this is OEIS complex. This is super complicated and really quite high morbidity for the fetus, which is going to form the next part of the discussion of things that I'm going to go into. It stands for omphalocele exstrophy. I've forgotten what INS stands for the moment. Spinal difficulties and imperforate anus, that's right. It's a cloacal exstrophy, essentially. You get failure of the infraumbilical body wall to close. You end up with an omphalocele, a cloacal exstrophy, imperforate anus, and spinal abnormalities. And that manifests itself most of the time as a dorsal dysraphism. What we find is an omphalocele, and the important thing with omphalocele is that you notice the umbilical vessels insert right on the tip of the omphalocele, and there's usually a membrane, and it's got fluid signal in it as well. That's how you diagnose the omphalocele. It's usually low because of the extrophy, but then there's a large midline inferior abdominal wall defect. That then gives rise to an infra-umbilical soft tissue mass, which is frequently called the extrophy mass. Okay, it's just a large kind of soft tissue abnormality with no really recognizable signal characteristics. If there's some bowel in there, you may see a small amount of high T1 signal, but it's very difficult to characterize it otherwise. Sometimes the hindgut will prolapse through the cloaca, and so you almost get an E version of the meconium signal coming out. It's described sometimes as an elephant trunk. The hindgut prolapses through the extrophy mass, and you end up with this kind of like long blind-ended tubular type structure in the amniotic cavity. Importantly, the bladder is not visualized. The liquor volume is normal because the kidneys are producing urine as they would normally, but the ureteric orifices are open out into the amniotic cavity. Finally, often you have a dorsal spinal defect, which can be anything from a kind of milocele all the way up to a really dreadful dorsal dysraphism with myelomeningocele and caudal regression. So here's the last case. This is a 26 plus 3-week-old fetus with complex abnormalities seen on ultrasound. They've got an infra-umbilical abdominal wall defect and a dorsal spinal defect. That's what we're going to see here, right? So this is an axial T2 haste. This is the fetus's legs. This is the spine, which we'll see again in a second, but this is that large kind of extrophy mass. But importantly, this, because it's a T2 turbospin echo type sequence, this is a flow void, and you can see that the cord inserts right onto the tip of this omphalocele, which contains a small amount of the liver. Same thing here. This is a sagittal T2 haste sequence. And you can see this is right between the legs, so we don't have the legs on either side. This is kind of like immediately sagittal through the pelvis. This is where the omphalocele is. You can see the vessels kind of inserting on top, and then this is the large extravasal mass with no bladder. It's very, very complicated. Lots of kind of different types of tissues in there, but it just looks like this large kind of conglomerate mass which just opens out into the amniotic cavity. But again, T1 sequence, really important in body imaging for these reasons. You can see no meconium signal. There's high signal liver here, high signal thyroid, and there's a few other organs which are high signal, but importantly, the meconium is absent, and that is problematic. You can see it very clearly here. It doesn't go to the perineal surface. And what else? We have this here. This is a dorsal dysraphism, the myelomeningocele, very kind of low, round about kind of like L1 towards the sacrum, but most of the sacrum is actually disappeared. Okay, this is a really severe case of caudal regression syndrome. You've got neural tissue in here with a placode inserting onto the outside. It's myelomeningocele, which you can see again just here. Okay, so super complicated, very, very difficult to fix postnatally, and we're going to talk about that again in a second. But once again, MRI, really useful for demonstrating the anatomy in this tissue. So what are the implications? Well, we come back to this question now. How disabled would our baby be if we continue with the pregnancy? And this is where I think MRI and the use of radiology in the fetal medicine, MDT, is so useful. We can help with diagnostic clarification. And for these patients, a simple, fairly straightforward bladder extrophy is quite easy for a expert pediatric urologist to fix. Minimal morbidity, very, very minimal mortality. Few patients in our experience will elect to terminate a fetus who has a bladder extrophy. Contrast that with your OEIS type complex, where they need input from pediatric surgery, they need input from pediatric urology. They may or may not have bladder function. They may or may not have bowel function. Importantly, that fetus will become a neonate, will eventually become an adult. So will they have any kind of sexual or will they have any urinary type function? You can do various different reconstructions, but depends whether that's going to work later on in life. And also importantly, you need input from pediatric neurosurgery as well. So all of these things have to be considered when they're counseling the patient, the severity of the disability and the postnatal quality of life, and whether the patient will or not therefore choose, in the UK at least, to go for a clause E late termination. Thanks very much. Very happy to take any questions, and look me up on either LinkedIn, Instagram, or send me an email, or I'm happy to stick around and take any questions in the chat.